Hello and welcome to Neurology Made Easy. So, today the topic we are going to discuss is Horner syndrome. Some of the members of Neurology Made Easy asked me to talk slowly. So, because some of them are non native English speaker, so now I'm talking slowly. Hopefully, everyone will understand. So, Horner syndrome has following features. First of all, ptosis of upper eyelid. This is because of the impaired function of superior tarsal and mural muscles. The function of superior tarsal and mural muscle is upper eyelid elevation. The second feature is slight elevation of lower eyelid. Actually, the inferior tarsal muscle causes lower eyelid to go down because it is impaired, so lower eyelid moves up. Third is pupillary miosis, which is due to impaired pupillodilator function that I will explain. Then we have facial hydrosis, that is sweating of half of the face is lost, and we also have anophthalmosis, that is decrease in palpebral fissure. So now I will explain why all of these happen in Horner syndrome. So for this it is important to understand the pathway of Horner syndrome. Actually, Horner syndrome is due to impairment in the sympathetic nervous system. It all starts from the hypothalamus. So we have we have first degree neurons, we have second degree neurons, and we have third degree neurons. So the pathway starts in the hypothalamus. Neurons from here go till level of C8T1. This is called ciliospinal center of Budge. Actually, when we see the cross section, the lateral parts of the gray matter, here we have this center. I'm trying to show it in a diagram. Sorry, my drawing is not very good, but I hope you will understand. So first synapse occurs here. Then the fibers move and we have a chain of cervical ganglia, inferior, middle and superior. The fibers pass through the inferior and middle, and they do not synapse in inferior and middle, but they synapse in the superior cervical ganglia. Here it is important that some of the fiber before they synapse in superior cervical ganglia, they leave and they go along with the external carotid artery that I'm going to show here, that at the level of superior cervical ganglia we have bifurcation of the carotid artery, and it divides into internal carotid artery that goes further up in the brain and the external carotid artery. So as I was telling you, the sum of the fibers before the synapse in the superior cervical ganglion, they leave and go along the external carotid artery and they supply the phase, the ipsilateral phase, and they are responsible for sweating. So that's why if we have impairment of this sympathetic chain, then there is loss of sweating on half of the face. Then the other fibers after the synapse, so the third order now go along with the internal carotid artery. I have tried to show that internal carotid artery passes through the carotid canal and then it enters the cavernous sinus, and it then moves up. So this cube I have shown as a cavernous sinus. So in cavernous sinus, we know that we have other important nerves also, that is third cranial nerve that comes from the midbrain, and we have fifth cranial nerve. Actually, we have third, fourth, fifth, and sixth, but now here we will talk about third and fifth. So the third, some of the sympathetic fibers move along the third cranial nerve, and and they go till the superior tarsal muscles, and they supply these. The third cranial nerve also supply the levator palpebrae superioris. So these fiber move with the third cranial nerve and supply the tarsal muscles. The fifth cranial nerve that arises from pons, and it also the ophthalmic division of the fifth cranial nerve. It later divides and form nasociliary nerve, and some of the fiber move along this nasociliary nerve, and they supply the muscles of the dilator pupillae. So when there is impairment of these dilator pupillae muscles, there is meiosis, and when there is impairment of the mular muscle or the tarsal muscles, there is ptosis. So you can see that first order neurons are from hypothalamus to the ciliospinal center of Budge. The second order are from ciliospinal center of Budge to the superior cervical ganglion, and the third order are from later on, afterwards, the superior cervical ganglion. Another important thing is the what are the causes. So the first order neuron, the damage can be due to tumors, trauma, stroke, multiple sclerosis, or degeneration, such as Arnold-Chiari syndrome. So anything within from the hypothalamus to the ciliospinal center of Budge can cause a lesion at first order neurons. The second order neuron, they can have this can be caused by Pankos tumor, because we have apex of lung, and any tumor here can cause. So Pankos tumor, subclavian artery aneurysm, dissection, brachial plexus injury, trauma, neuritis, or CVP line, damage to the CVP line can cause second order neuron damage. Third order neuron damage can be due to cavernous sinus thrombosis, internal carotid artery aneurysm, middle ear infection, or herpes infection. Now I will tell you about the test, how to differentiate between whether it is this lesion is Horner syndrome or not, or this. The first test is cocaine test. We give 4 to 10% cocaine, 2 drops in each eye. Cocaine actually inhibit the norepinephrine reuptake, so we have more norepinephrine in the area of synapse. In case of normal eye, it will dilate. However, in case of abnormal eye, even there is more norepinephrine, but because there is some problem in the pathway, the eye will not dilate. So but it will not differentiate between this whether it's first, second, or third order. So the other test is hydroxyamphetamine. In case of hydroxyamphetamine, there is release of stored norepinephrine. If there is dilatation after giving hydroxyamphetamine, then it means that third order neuron are okay and there is problem in first or second order neuron. So it's briefly I have told you about Horner syndrome, its pathway, lesion, localization and test. Hopefully you will understand. If you have any question, please free ask.